Okay, antipsychotics, these are indicated for schizophrenia, bipolar disorder, and other psychotic disorders. They block dopamine, among other things. So some of them involve norepinephrine, some involve histamine, serotonin, acetylcholine, but the main concern as far as drug mechanism are that they block dopamine. There are two categories, typicals or conventional, and then atypicals. The typicals are older. They have more side effects because they have decreased selectivity for the receptors, and these are not commonly prescribed. As you can see, none of the ones I have listed here are in the top 200. And again, the lists that I have are not all-inclusive. They're just a reference point, and I certainly tried to include the more commonly used ones. If there were a top 200, I was sure to put that on here. The atypicals, so this is kind of the second generation, they have their own set of problematic side effects, but however, we consider these a little more safe, and they're much more commonly used. So we have aripiprazole or Abilify, clozapine, Clozaril, olanzapine, Zyprexa, paliperidone is Invega, quetiapine, Seroquel, risperidone, Risperdal, and ziprasidone, Geodon. Now, the typicals are the first list, the first generation. They have, you can see blood pressure changes, dizziness, constipation, dry mouth, blurred vision. But the one that stands out for this group, the one side effect is the movement disorders. And physicians might refer to it as the extrapyramidal symptoms, or EPS. So this has to do, all these have to do with movement disorders. Dyskinesia, that is involuntary tics or spasms. Dystonia, abnormal sustained muscle contractions. And these are not, the dyskinesia, these are not just, these are painful, sustained muscle contractions. So these are very painful for the patient. Pseudo-Parkinsonism, so that's going to appear like someone with Parkinsonism. And tardive dyskinesia, this is usually caused by long-term use of these medications, and it's just repetitive, involuntary movements. Usually you see it in the face. Person might stick out their tongue, smack their lips, blink their eyes. Sometimes, however, arms and legs are involved as well. So this can be a irreversible condition, but it's serious and a big problem with this class of medication. Black box warnings, increased mortality in elderly patients with dementia-related psychosis, and there's a couple of specific ones there that can prolong the QT interval. And there's a list there of other warnings, EPS, which we already mentioned that. And NMS, this one can be life-threatening. It sort of has the same symptoms as serotonin syndrome: increased body temperature, sweating, unstable blood pressure, muscle rigidity. But I think for this, the main one we want to remember are the EPS, or the movement disorders. For the atypical antipsychotics, or the second generation, the one that stands out here are going to be the metabolic disorders. So weight gain, hyperglycemia or elevated blood glucose, dyslipidemia. So those are the ones that we want to remember for the atypicals. Also, not terribly common, but serious would be QT prolongation. Black box warnings, same thing for increased mortality in elderly patients with dementia-related psychosis. And clozapine, this one has a lot of black box warnings, and it for this reason, I don't really see it prescribed that much, and it, of course, wasn't on the top 200 list. And the others are listed there as well. Some literature suggests that 2D6 poor metabolizers and intermediate metabolizers are more likely to experience the EPS. There was I believe it was a meta-analysis study that showed poor metabolizers have 43% higher risk of developing tardive dyskinesia compared to extensive metabolizers. And there's a link there at the bottom of that slide where you can go check out that study. Typical antipsychotics, perfenazine or trilofan 2D6. So again, 2D6 is one that we keep visiting here for our psychiatric medications. Poor metabolizers of 2D6 will metabolize perfenazine more slowly and experience higher concentrations compared with normal or extensive metabolizers. Poor metabolizers demonstrate these higher concentrations at usual doses, which may correlate with the emergence of side effects. So we can assume that based on just what we know about what a poor metabolizer means, but this actually is stated in the package insert for perfenazine. ORAP, this one has specific guidelines for dosing. It recommends for patients that are 2D6 poor metabolizers, well, it says if we're giving a child a dose above 0.05 milligrams per kilogram per day, genotyping, 2D6 genotyping should be performed, and if they in fact are a poor metabolizer, they should not exceed that dose. And for adults, the dosage is 4 milligrams. So if you're going to dose over 4 milligrams, genotyping should be performed, and if they are a poor metabolizer, the physician should actually stay below the 4 milligram mark. Abilify aripiprazole, this one gives us pretty solid recommendations as well. Poor metabolizers, the physician should start them on a dose that is 1/2 the usual dose and then adjust it for a favorable clinical response. Now, if we have a poor metabolizer who's also given a 3A4 inhibitor, their dosage should be reduced to 1/4 or 25% of the usual dose. So this ORAP has some specific guidelines for not only poor metabolizers, not only we're talking about taking inhibitors, but they've got combination. If one is a poor metabolizer and taking an inhibitor, it provides the physician with guidance as to what they might consider. Quetiapine 3A4 and risperidone 2D6. Quetiapine, this one talks about specific drug interactions. So we would want to check out the package insert for that. And I don't have it on here, but ziprasidone or Geodon, it gives the same information. So check out the package insert. Risperidone, this is another one that has an active metabolite, but the pharmacogenetics of the parent compound risperidone and metabolite combined are similar in normal and poor metabolizers. So this was kind of similar to Effexor or venlafaxine in that we have this active metabolite, but when we look at it from the perspective of the parent compound and the active metabolite, we have the same levels in a normal metabolizer and a poor metabolizer. So in this case, a dosage adjustment may not be necessary. CNS agents. First, we'll talk about stimulants indicated for ADHD and narcolepsy. Amphetamine, dextroamphetamine, sometimes we just call it amphetamine salts, but this is going to be generic Adderall. Dexmethylphenidate is Focalin. Dextroamphetamine is Dexedrine and Procentra. Lisdexamphetamine, Vyvanse, and methylphenidate is Concerta, Daytrona, Metadate, Methylene, Ritalin. These inhibit the reuptake of norepinephrine and dopamine. So side effects, elevated blood pressure, increased heart rate, anxiety, dizziness, headache, GI disturbances, weight loss. Warnings, all of these medications are controlled substances, and they're actually a Schedule II, so they have a very high potential for abuse and dependence. Cardiovascular effects, sudden death, drug-dependent seizures, and many other warnings. Adderall's package insert says that although the enzymes involved have not been clearly defined, 2D6 is known to be involved, and since 2D6 is genetically polymorphic, population variations in the metabolism are a possibility. So for CNS agents, non-stimulants, the one we have is Strattera or Atomoxetine. It is a selective norepinephrine reuptake inhibitor used for ADHD. GI disturbances, decreased appetite, decreased weight, drowsiness, increased heart rate, increased blood pressure, and a lot of times we'll see those types of side effects if we're dealing with something that has to do with norepinephrine. Sexual dysfunction and headache, very similar panel of warnings here. The black box warning, cardiovascular effects, and this one actually has hepatic or liver effects also. The package insert for Strattera tells us that poor metabolizers of 2D6 have a 10-fold higher area under the curve and a 5-fold higher peak concentration compared with normal metabolizers. So increased levels in poor metabolizers when compared to normal or extensive metabolizers. It also provides us with very specific dosing. In children and adolescents up to 70 kilograms who are 2D6 poor metabolizers, the dose should be initiated at 0.5 milligrams per kilogram per day and only increase to the target dose if symptoms fail to improve after 4 weeks and the dose is well tolerated. So there's also a recommendation for adults as well, but the bottom line here is that if they're a poor metabolizer, the physician is probably going to consider starting them at a low dose and just titrating upward to a target dose very slowly. Here's some facts and statistics just for you guys to look over, might help you with when you're talking to the physician. A main one here is 6.3% of extensive metabolizers and 11.2% of poor metabolizers discontinued Strattera or Atomoxetine because of an adverse reaction. And you can read through those as well, but these come straight from the package insert for Strattera. Drug interactions, 2D6, again, talking about inhibitors, but remember paroxetine and fluoxetine, those are 2 SSRIs that we talked about that are potent 2D6 inhibitors. Also, they are metabolized by 2D6, but in this case, we're just looking at them as an inhibitor. So they can increase Strattera concentrations and make someone appear to have the same effect as if they were a poor metabolizer. So if you give an inhibitor to an extensive metabolizer, they might appear as a poor metabolizer as far as their drug levels. Also, we want to watch out with QT prolongation drugs and MAOIs. Anxiolytics, benzodiazepines. These are used for anxiety, panic disorders, seizure, and insomnia. All of these are commonly prescribed. You can see of the ones I have listed, only one of them is not in the top 200. Alprazolam or Xanax, clonazepam, Klonopin, diazepam, Valium, lorazepam, Ativan, and temazepam, Restoril. These bind to the GABA receptor and enhance GABA and its inhibitory effects on neuron excitability. So GABA is more of an inhibiting enzyme, so we want to enhance the effects of that when we're trying to calm anxiety or cause drowsiness for sleep. So, of course, these are going to cause drowsiness as a side effect. They can cause confusion, blood pressure changes, incoordination, memory impairment, sedation, GI disturbances. These are also a controlled substance. These are Schedule 4, so they have a risk of dependence and abuse, and warnings also suicidal thoughts and seizures. Alprazolam is 3A4, diazepam is 2C19 with the minor pathway of 3A4. The package insert just talks about specific drug interactions and what recommendations, which we would just refer the physician to that. Drug interactions, the SIP, so since we're dealing with 3A4 and 2C19, we want to consider those depending on which drug we're talking about. Also, CNS depressants, other medications like narcotics and alcohol could just enhance the drowsiness and the side effects that are already present with the benzodiazepines. Interesting fact, diazepam has active metabolites, and the metabolites are two other medications, or two other benzodiazepines that are on the market. One of them is temazepam or Restoril, and oxazepam or Serax. So diazepam has a long half-life when we consider the two metabolites. Also, withdrawal, seizures can occur if there is abrupt discontinuation. So a lot of times we want to see a gradual taper from these medications. Miscellaneous agent, Buspar or Buspirone. This one is used for anxiety. It does not affect GABA binding, but we're not really sure of its mechanism of action. It causes dizziness, headache, confusion, nervousness, GI disturbances. This one is not a controlled substance. It lacks potential for abuse, and it is less sedating than the benzodiazepine. As far as the drug information and the label, discusses specific CYP450 drug interactions and recommendations. Our non-benzodiazepine hypnotics, also used for insomnia, are going to be Atopical, Lunesta, Zaloquan, Sonata, or Zolpidem, Ambien, Ambien CR, and a new one that just came out, Intermezzo. The mechanism of action on these is not fully understood, but it probably does involve GABA. Adverse effects, GI disturbances, daytime drowsiness, headache, dizziness, diarrhea. Warnings, behavior changes, so decreased inhibitions, hallucinations, sleep driving, also depression and dependence, because these are a Schedule IV and they have a risk of dependence and abuse. You can see 3A4 is the major pathway for both Lunesta and Ambien, and we would have to consult the package insert for specific recommendations about CYP drug interactions.